Okay, it looks like all of the participants have been able to join, and we'll go ahead and start this session today. My name is Kirk Schultz, the moderator for the session, part of the ECHO program, sponsored by the GVHD Interactive Provider Network. The presenters today will be Jeff Cuvillier and Iskra Pusic. Let's make this go forward. Just want to welcome you to the ECHO program. And the goals of this program have been to provide interaction between GVHD specialists and community providers to share expertise with some of the people with experts in the field. It's based on the ECHO model, which stands for Extension for Community Healthcare Outcomes. These sessions are designed around case-based learning and mentorship. Target audience for the ECHO program is CE activity intended for physicians of all specialties, nurse practitioners, physician's assistants, and other healthcare professionals who treat chronic graft versus host disease. And our educational objectives in this session today, as well as the ones in past and in future, after completing this, you will be able to explain about chronic GVHD atypical manifestations in organ systems, discuss what is known about chronic GVHD in the various organ systems involved, and integrate this into your management for atypical chronic GVHD, and including the limitations. I've just given you the welcome, and this is our agenda for today. This will be followed after I finish by Dr. Jeff Cuvillier, who will take us through about a 20 to 25-minute presentation on a didactic presentation around atypical GVHD and discuss the NIH paper that was recently published on this topic. And Dr. Iskra Pusic will present a couple cases for discussion, and then we will save 10 minutes at the end for an open discussion for any kind of questions that you might have. If you do have a question, you can type it into the chat, or when we open it up for open discussion, you can raise your hand and you'll actually be able to ask a question toward the end. This is the accreditation information. I'm not going to read through all of this slide, but just to give you what this is about for the accreditation that you'll be able to get from the course today. Faculty disclosures are as follows, and I just give you a brief minute to take a look at these. And also for the rest of the disclosures. Just going through this is some additional material we just need to cover before we get started. And I'm just going to give you a brief, and again, that this will be in the recorded session if you want to read it in more detail, but I'm just spending a brief moment on this. So the ECHO program has been set up. This is, again, want to take our hat off to the Aplastic Anemia MDS International Foundation, who has sponsored this. This is partnered with Meredith Cowden Foundation and Be the Match. And it's, I have really enjoyed the first 4 sessions, and I hope you enjoy this one today. This will be recorded, and you will be able to look at it later. And as I've said already, there for questions, please type any questions you have in the chat. And we will have toward the end time for verbal questions, and ask you to raise your hand at that time. Some helpful points is to keep your camera on during the program, mute your microphone, please. And as I've already said about raising your hand, and just state your name and your institution when you do ask a verbal question toward the end. We're going to go ahead and get started. I'm going to just stop my sharing, and Jeff is going to come on. And Jeff Cuvillier is at the University of Manitoba, at the Cancer Care Manitoba, and a pediatric hematologist oncologist who's specialized in chronic GVHD. Take it away, Jeff.
Okay, thank you very much, Dr. Schultz, and welcome to everybody here this morning. Thank you very much for the opportunity to give a presentation this morning on the atypical features of chronic graft versus host disease. And I'm going to emphasize a lot initially about the challenges with actually coming to atypical chronic GVHD diagnosis. My disclosures are a consultancy honorarium from Miltenyi Biotech. There's no disclosures related specifically to this talk. As Dr. Schultz already mentioned, we're going to have 3 basic objectives. We're going to be explaining how chronic graft versus host disease can present with some atypical manifestations in organ systems that are not classically described by the NIH consensus criteria. We're going to discuss a little bit what is known and what is not known about chronic graft versus host disease that involves the hematopoietic system, the peripheral and central nervous system, musculoskeletal system, and the kidneys. And we're going to review how to integrate the assessment of atypical chronic GVHD into patient care, including some of the limitations of doing so. So just as way of background, and as I'm sure that everybody who's on this call is already aware.
Jeff, if your slides aren't advancing, you need to go into presentation mode, please.
Okay, I am in presentation mode.
It's showing your slides on the side.
Okay, just a second. Sorry here. Sorry, everybody. Mine does say that it is in presenter mode.
Okay, well, go ahead and at least just get down to I think you're on slide 3 or 4, but it's still showing your first slide.
Okay, is it moving now?
Yeah, and again, it's not in presentation mode, so we can see the slides on the left.
Okay, sorry about that.
Yeah. Shoot.
Sorry, everybody. I'm going to have to leave it like that. I'm not sure how to.
Or something like, what is
You
this?
just
program?
click slideshow, maybe it will do it. Go up to the slideshow on the bar.
I think it's okay, Jeff. You can go
Okay,
ahead.
we're
and see the
gonna
slides
get
well.
going like this so that we don't end up. Okay, so I'm sorry about that, everybody. So the National Institutes of Health consensus projects were started 17 years ago, and there have been 3 iterations of these to date in 2005, 2014, and 2020. And these represent the most up-to-date knowledge and the expert perspectives on chronic graft versus host disease and cover all aspects, including diagnosis, pathology, supportive care, biology, response, and clinical trials. In particular, in the 2005 and 2014 diagnostic and staging working groups, there was what we now refer to as the NIH consensus criteria that describe the ways with which we should be diagnosing chronic graft versus host disease using contemporary mechanisms to do so. These also describe the severity scoring by organ system, as well as more global severity scoring of chronic graft versus host disease. And these diagnostic and staging criteria were used really to help clinicians aid in their clinical evaluation of patients, while also providing standardized and minimal diagnostic criteria for entrance into clinical trials. The 2005 and 2014 NIH consensus criteria introduced some important concepts around graft versus host disease, and particularly for chronic graft versus host disease, separated it as a distinct syndrome from acute chronic graft versus host disease, and really importantly, established that chronic graft versus host disease could occur at any time after transplant. It was no longer seen only after day 100 and rather was a time-independent phenomenon. There were 8 classic organ systems, including the skin, the mouth, the eyes, the oropharynx, the lungs, the musculoskeletal system, the liver, the gastrointestinal system, that were considered to be the classic organ systems. But what we're going to talk about more are the other organ systems and how they may very well be affected by atypical chronic GVHD, and had a variety of clinical manifestations and severity. What was really important about this was that the manifestations of chronic GVHD could be divided in those that were diagnostic. And the picture that you see there, which is poikiloderma and sclerosis, that's a very diagnostic feature. If you see that, you don't need to have a biopsy. Distinctive manifestations were those that were quite often seen in chronic GVHD, but may very well need to have an additional test to help to establish the diagnosis. Common features were those that could be seen in both acute and chronic graft versus host disease and were felt to be not specific enough to establish the diagnosis. And then finally, there was this other category called the other manifestations. And that's what we're going to focus on here today. And these were manifestations that were felt to be rare or where it was uncertain if they were in fact related to chronic graft versus host disease. In the 2020 NIH consensus form, when we were doing the highly morbid forms report that really looked at chronic GVHD affecting the skin and the lungs and the ocular system, it was recognized that chronic graft versus host disease often manifested in atypical ways in classic organ systems, and it may also impact the non-classical organ systems. But there was really very little that had actually been written about this. And so about a year and a half ago, we took upon the project of trying to look at all of the available evidence around the atypical chronic GVHD features that might contribute significantly to patient morbidity and mortality. And the article that I'm going to mostly be referencing is this one that was published in Transplant and Cellular Therapy earlier this fall, that it really summarizes the most up-to-date knowledge on the atypical features of chronic GVHD. And the objectives was to define what is known and what is not known about these atypical features, to provide clinicians and researchers with provisional diagnostic criteria for the atypical features, and then to develop a research agenda for the next 3 to 7 years to help to understand these atypical features better. This is the major figure that was presented in, and what you can see on your right are the features that we already defined, called the NIH-defined chronic GVHD target organs and manifestations, with those in bold representing diagnostic features. By comparison, on your left are the atypical chronic graft versus host disease organs and manifestations that may have features in relation to chronic graft versus host disease. And you can see the various organ systems, including the central nervous system, the peripheral nervous system, additional features in the lungs, the serosal membranes, the kidneys, the musculoskeletal system, as well as immune-mediated cytopenias. Some very important things just to mention about the atypical chronic GVHD features is that we don't necessarily know a lot about all of these. And the relation to chronic GVHD from a pathophysiologic perspective may be uncertain. The level of evidence as features in many of these may not be high. And so this in some ways becomes a bit of a discussion about whether these really truly do reflect chronic GVHD. Secondly, if you look at disorders like ITP and myasthenia gravis, are these actually in fact closer to their initial autoimmune counterpart and have nothing really to do with chronic GVHD, or in fact, are they part of a larger chronic GVHD syndrome? And why this is important is because this may actually influence how we may start to conceptualize treating these particular atypical features. If they're more like their autoimmune counterpart, we might use treatments that are already well established. But if they're part of chronic GVHD, we may need to start thinking about it from that sort of a perspective. For the clinicians, this is really important, is that there are many confounding factors that hinder the assessment of causality. We know that many medications and many infections that transplant patients have very similar clinical features to many of the atypical features, and they may be present at the exact same time. And this makes the clinical assessment very difficult. And this is particularly challenging for clinicians when an atypical manifestation occurs in isolation without any other diagnostic chronic GVHD features. This is from a paper published by Ken Cook and colleagues a few years ago that really is a nice outline of the pathophysiology of chronic graft versus host disease. And what I really would like to try to emphasize is that when you look at what we do know about the pathophysiology of atypical chronic GVHD, there is a significant component of it that relates to the area around chronic inflammation and dysregulated immunity and lack of central and peripheral tolerance. Furthermore, we know that a lot of these features have got to do with endothelial damage. And in the paper, we talk about what we know about the endothelium being a target of chronic graft versus host disease and its relation to things such as cardiovascular disease, myocardial infarctions, increased incidence of deep venous thrombosis in patients who have chronic graft versus host disease. In the paper, we provide a number of provisional diagnostic criteria for the atypical chronic GVHD manifestations, and the particular diseases are all listed there. I would refer people to the paper for more detail because we're not going to have time to cover all, but I am going to try to focus on a few of these that we sort of think are highlight disorders. So first of all, I'd like to chat about immune-mediated cytopenias and their relation to chronic graft versus host disease. We know that disorders like ITP and autoimmune hemolytic anemia, autoimmune neutropenia, and Evans syndrome occur in about 2 to 8% of patients after allogeneic transplant. Of course, we're all well aware that there are many reasons for cytopenias after transplant, and it makes us wonder whether immune-mediated cytopenias are perhaps under-recognized. If you look at the studies that look at immune-mediated cytopenias after allotransplant, chronic graft versus host disease remains a risk factor on multivariable analysis in some, but not all, chronic GVHD studies. We know that children have a higher rate of immune-mediated cytopenias, particularly when they're transplanted for non-malignant disorders and with cord blood. But one of the fundamental problems is that we don't at this point have a true understanding whether immune-mediated cytopenias represent the donor transplanted immune system reacting against itself in an autologous way, meaning donor immune system against donor, or in fact, is this donor versus recipient cells, for instance, host red cells or platelets that may not have necessarily been gone with the conditioning regimen. In this very, very nice paper published by Natasha Buxbaum and Steve Pavletic, published about 2 years ago, they really illustrated what is known about autoimmune disease in the post-transplant setting. And one of the factors is that central immune tolerance is often lost. And there can be a variety of reasons for this, including things like acute graft versus host disease that may impact the thymus, simply age, and older individuals may not have a robust thymopoiesis. And what that means is that we're dependent more upon peripheral immune tolerance and regulatory T cells after transplant to help regulate. And what they have nicely shown is that when peripheral immune tolerance is also compromised, you're at much higher risk to get autoreactive B cells that produce. And in the particular situation for autoimmune hemolytic anemia, we know that individuals can have pan-reactive autoantibodies against red cells that result both in an intravascular hemolysis through complement as well as an extravascular hemolysis through the reticuloendothelial system. What about central nervous system and chronic graft versus host disease? Well, there are a wide variety of clinical syndromes that are suspected as being due to chronic graft versus host disease of the central nervous system. It has been reported for conditions such as acute disseminated encephalomyelitis, a multiple sclerosis-like presentation, and a CNS vasculitis with T-cell infiltration. The problem is that these are not necessarily the most common things that are seen. And what is more often seen, particularly in adults, when up to 60% can have some form of neurocognitive dysfunction, often in the form of things like problems with attention, memory, executive functioning, anxiety, and depression. And so the question is this in fact related to chronic GVHD, or is it related to other things such as medications? And in this really nice paper that Kelly McDonald and her group out of Australia published along with Rachel Adams as the first author, just recently published in Blood, using non-lethal chronic GVHD mouse models, were able to detect donor cells actually infiltrating into brain parenchyma. And so in their mouse models, what was initially seen was initially a very high CD8 T cell infiltration of the brain about 2 weeks after transplant, that then declined over the next month or two, such that by about 70 days, there was an increase in CD4 T cell infiltration and bone marrow donor-derived macrophages that took on a phenotype similar to host microglial cells, although they were transcriptionally different. Importantly, this was all mediated by high interferon gamma that produced generalized neuroinflammation and resulted in the mice showing defects in spatial learning and memory. And this was really the first time that it was really demonstrated that chronic GVHD of the central nervous system is quite likely a real phenomenon. And because of the high levels of interferon gamma, it might suggest that drugs such as ruxolitinib that block downstream JAK-STAT signaling could potentially reduce neuroinflammation and improve cognitive functioning in chronic GVHD. What about in the peripheral nervous system? It appears to be less commonly impacted, where chronic alloreactivity is felt to represent perhaps somewhere around 0.7 to 6% of allotransplant patients, even though about 40 to 50% of adult patients may have some evidence of peripheral neuropathy after transplant. In terms of the particular diseases that have been seen, chronic inflammatory demyelinating polyneuropathy, myasthenia gravis with anti-acetylcholine receptor antibodies. Interestingly, about 20% of transplant patients will have anti-acetylcholine receptor antibodies after transplant, but they don't necessarily all develop a myasthenia gravis-like syndrome. Guillain-Barré, radicular plexus neuropathies, and mononeuropathies. How is this actually practically evaluated? Well, again, in this concept that many different causes can cause peripheral neuropathy. And from a clinician's point of view, it's important to state that you don't want to forget to rule out things like nutritional deficiencies, paraneoplastic events, infections, and neurotoxic drugs, all of which are really important in transplant patients. And in the paper, I'm not going to spend a lot of time, but really a good physical examination by a neurologist that really understands the peripheral nervous system and the combination of nerve conduction system and electromyography can actually help to try to separate this out. And a related topic, musculoskeletal chronic GVHD, and in particular myositis. We know that muscle cramps are a prominent cause of poor quality of life in individuals who have chronic GVHD, but this unfortunately is a very non-specific symptom and it likely has multiple causes, including not just chronic GVHD of the muscles, but also peripheral neuropathy. Proximal muscle weakness can often be seen, but again, that can be confounded often by things like steroid myopathy. We know that chronic GVHD myositis likely affects 1 to 3% of allotransplant patients. It is likely underdiagnosed. And why? Because muscle biopsy remains the gold standard, but of course it isn't really necessarily performed in a lot of patients because it's quite invasive. What we try to emphasize is that clinicians can use other things like creatine kinase, aldolase, electromyography, nerve conduction studies, and MRI to help to try to form causality. In the paper, we describe ways with which these subsequent tests might be used to help differentiate chronic GVHD myofasciitis from chronic GVHD-induced peripheral neuropathy, as well as steroid myopathy. And Dr. Pusik is going to present a case where this is going to show how this can actually be applied in clinical practice. Here's an example of an MRI of a patient who has chronic GVHD myositis, and you can see the MRI findings of fatty infiltration and superficial and subcutaneous edema that correlates with an increase in the creatinine kinase. Muscle biopsies, as stated, are not often performed, but if they are, CD4 and CD8 T cell infiltrates and endomysial fibrosis can be seen. And this can actually help to go on to establish that this may be myositis related to chronic graft versus host disease. Very briefly, what about chronic graft versus host disease involving the kidneys? We have noted for a long time that disorders such as nephrotic syndrome are well associated with chronic GVHD. And again, this speaks to the endothelial dysfunction and the endothelium being a component of chronic GVHD alloreactivity. In our atypical manuscript, we actually make some clinical suggestions that clinicians want to start looking at things like blood pressure, reviewing of nephrotoxic meds, but also doing things like urinalysis and urine albumin to creatinine and urine protein creatinine ratio at various time points, usually around 1 to 3 months after transplant, as a way to screen for this. So how should clinicians determine if a clinical manifestation is due to an atypical chronic GVHD manifestation or not? Well, the NIH consensus paper acknowledges that this is very, very difficult. And we suggest good clinical description of the problem, the association with other chronic GVHD features, trying your best to do the extensive investigations that may ultimately need to include biopsy, and trying to rule out non-alloreactive causes. We have proposed that one should ascribe the cause of a suspected atypical manifestation to chronic graft versus host disease when other chronic GVHD features are present, either concurrently or in the past, and when alternative causes have been reasonably ruled out. The problem is, and this at least at the level of expert opinion, is that many of the purported atypical chronic GVHD manifestations seem to occur in relative isolation and often as immune suppression is weaned, which makes it very difficult because you may not have other chronic GVHD features to try to help to come to causality. In the manuscript, we give clinicians some suggestions for initial evaluations. for workup of the atypical manifestations, as well as some additional secondary evaluations according to what the manifestation is, as well as provide our perspective on what sort of research evaluations are needed in the next 3 to 7 years to help to try to sort this out. And of course, we need to address the gaps in knowledge about atypical chronic GVHD, and this really is a paper that gives a call to action for the next 3 to 7 years to try to begin to develop multi-institution prospective observational studies that capture all of the purported atypical chronic GVHD manifestations that combine excellence in clinical description of what confounding factors are present, laboratory correlates, and timed and event-driven biomarker assessments of the atypical manifestations. And with that, we're going to be moving on to some cases that Dr. Pusik is going to be describing. I just want to send some acknowledgements that there were a number of individuals with expertise, both on subspecialty and chronic graft versus host disease, with particular acknowledgement to Dr. Daniel Wolf and Dr. Stephen Pavletic, who were the senior authors on the paper. And with that, I will send off to Dr. Pusik.
Thank you very much. And let me now share my screen. Do you see the slides? So, do you see my presentation?
We do not, as of right now.
You do not. Hold on.
No, we don't. It worked before when you were doing it.
Yeah, it did. So I'm not sure why. Okay.
There you go.
Now we go.
Yep.
So I am Iskra Pusic from Washington University School of Medicine in St. Louis. And I will show you several cases. So the first case, just to put things in perspective, was happening between 2007 and 2012, when this young man who had a very high risk and refractory ALL was transplanted, and he was transplanted with some degree of persistent disease. He received a graft from fully matched unrelated donor, peripheral blood stem cells. He received TBI as part of his conditioning. He had standard GVHD prophylaxis for the time. And then he received a prophylactic DLI after transplant, considering his high-risk disease. And then about a month after DLI, he had some acute GVHD involving his skin, stage 3, that resolved with tacrolimus and a pulse of steroids. But then about 4 months later, as tacrolimus was tapered off, he developed some oral lichenoid GVHD and some lichenoid and hyperpigmented skin changes, and started having complaints of dry eyes. And this was thought to be consistent with him developing chronic GVHD. He was given another pulse of steroids. His tacrolimus level was made therapeutic. His symptoms persisted and progressed, and then sirolimus was added. And even though he had some initial improvement, he then was worsening again, and he thought that maybe this was related to sirolimus, so sirolimus was stopped, and mycophenolate was added. But with time, none of this worked. He probably received another pulse of steroids somewhere in between, but his symptoms continued to progress. And he had some, though quite minimal, sclerodermatous changes, but then developed overwhelming pruritus and generalized skin pain known as allodynia. And they're very prominent musculoskeletal system involvement with edema that went to progress to generalized anasarca with really profound interstitial pitting edema that was unresponsive to various diuretics. And then extensive workup was done that are listed here. He had completely normal 2D echo, completely normal PFT set at the beginning. CT, Dopplers were completely normal, and various labs such as liver function, creatinine, albumin were all normal. And then he started developing further muscle cramps with myalgias, evidence of myositis, arthralgias, joint swelling, and some proximal muscle weakness. And again, further evaluation showed here that his CK and aldolase were elevated. All imaginable autoantibodies were tested and were all negative in normal limits. His ESR and rheumatoid factor were normal, and there was no any evidence of avascular necrosis or infection. He also had some evidence of serositis with some small pleural effusions. So I want to show you some photographs where you can see this young man who was naturally very slim, who now has this really overwhelming and generalized edema involving all of his body, but most prominent on his extremities. And you can see maybe some sclerodermatous changes here around the waistline, but mostly his skin was kind of soft when you would feel it, with then some lichenoid areas and this overwhelming edema. And again, here you can see how his lower extremities look like. I don't have the picture of his MRI. This is a picture of MRIs that Dr. Cuvelier showed you, but this is kind of a typical finding where you can see that there is some skin thickening and some edema subcutaneously and around the fat, and then overlying edema overlying the fascia of the muscles. Aside from that, he had several other organs involved. He had keratoconjunctivitis, Zika with Schirmer's that were measured at the time and was 0. He had dry mouth with some tongue atrophy. He had initially normal PFTs, but then with time, he developed combined obstructive and restrictive ventilatory defect, and then later on, more predominantly restrictive issues. He had peripheral neuropathy, hypogammaglobulinemia, and then this young, normally very jolly and upbeat man, of course, was struggling with worsening fatigue, anxiety, and depression. And if we look at his treatment history, at the beginning, these were the usual suspects: prednisone, tacrolimus, sirolimus, mycophenolate. Then when that didn't work, we had a study open at WashU, which was the first time ever using pomalidomide for chronic GVHD. Later, similar study was done at NIH, but at this time, this was the first time pomalidomide was used for that indication. And he was on it for about 3 months and did not tolerate it well at all. He had worsening cramps, worsening fatigue, and then he was discontinued from pomalidomide and received a couple of rounds of the clizumab that we were able to get for him, and was started on ECP that maybe worked a little bit at the beginning, but then he continued to progress. Was tried on rituximab and imatinib, and this was 2009. So this was before these drugs were compared head-to-head in a multi-center trial. And when that didn't work, we sent him to our colleagues at NIH, where he was extensively evaluated, had additional biopsies, additional imaging, and additional kind of advices. We all put our heads together how to treat him. However, he continued to progress and was again receiving a high dose of steroids at the time, some cyclosporin, and then he was sent to Dana-Farber's that had IL-2, I think in combination with sirolimus study. However, did not respond. And actually, after he returned from there, he had new skin ulcerations and severe infection, ended up in the ICU for a period of time. And when he recovered, he was tried on methotrexate and bortezomib that in the end he progressed through. And then as a desperate measure to try to get his GVHD under control, he underwent second allogeneic transplant from a different and unrelated donor. And unfortunately, throughout that process, he passed away. So I will bring back this table that Dr. Cuvelier showed you, just to kind of underline these differences in somebody who has chronic GVHD-related myofasciitis, and some other alternative diagnoses that we can contemplate, primarily steroid myopathy. And we can I can bring back Dr. Courbier. What I want to underline here is that also muscle pain is something that is much more pronounced in myofasciitis and usually not present in steroid myopathy. And then findings on muscle biopsy and on the MRI that are abnormal with chronic GVHD myofasciitis. And today is 2022, and this is the quote for the paper that we were already talking about earlier. And really, even though the years has passed and we now have 3 drugs that are available for treatment of chronic GVHD and FDA approved, really no current data exists regarding specific treatment recommendations, and usually you follow the general guidelines. So I guess nowadays we would try these new drugs and not necessarily do a second transplant, but I don't know whether we would be more successful. So I would like to bring Dr. Courbier back if he would like to give additional comments.
Yeah, thank you. That's a very sad case, but I think it really does illustrate atypical features. And I guess my first comment is how would we assess this now in 2022? And you certainly have described a number of things that are very well known with chronic GVHD, with the skin changes and the lichenoid changes. But just to illustrate to the people who are listening is that there are a bunch of things that you presented that we would now suggest, or at least we'd say these are very highly likely part of chronic GVHD syndrome. And that includes the edema, the anasarca, the potential peripheral neuropathy, the myositis that was described. And interesting also the restrictive lung disease. One of the things that we recognize in the atypical paper is things like idiopathic pleural pulmonary fibrosis that may very well show up like this, that isn't necessarily bronchiolitis obliterans. So absolutely, this is a patient who one might consider doing things like nerve conduction syndrome, nerve conduction studies, and in EMG to try to figure this part on out. But as you've clearly shown, the muscle pain, which we described as being something very common and also a significant problem for quality of life in these patients as being a real phenomenon. And you're absolutely correct. We still don't have any good data. I'm interested. I've heard anecdotally of some individuals suggesting that things like just supplementing the magnesium helps their muscle pains. I'm not aware of any data. I'm interested if you have ever heard that before. It's actually one of the things I've heard on the chronic GVHD chat groups. I've heard other people using things like benzodiazepines to help with muscle pains, but I'm not certain if there's any clear thing from a symptomatic point of view. And then I guess my next comment is that, as you pointed out, Dr. Pusick, that absolutely we have newer drugs nowadays, ruxolitinib, ibrutinib, and the like, and the ROCK inhibitor that certainly may be options that one might want to try in this day and age.
Yeah. Thank you for these comments. Yeah, and absolutely, we did replace his magnesium, have him drink tonic water, and various other as ancillary measures, which were only marginally successful. Yeah.
And I'd like to encourage all the participants, if you have a question, type it in the chat or raise your hand, and we'll try and get it in there as we go through the cases. I think you have 2 more, Iskra, is that correct?
Yeah. Yes.
Okay, take it away.
So the second case was a woman, 45-year-old. She had a transplant in 2006, also unrelated donor, single dose TBI as a part of conditioning. She didn't have significant acute GVHD. And then she went on to develop severe steroid refractory chronic GVHD. And she had a variety of NIH-defined chronic GVHD manifestations with sclerotic skin changes and subcutaneous thickening with keratoconjunctivitis sicca, with lichenoid changes in her mouth and erythema, and some moderate joint stiffness. But then she also had a variety of atypical chronic GVHD manifestations with some diffuse edema that was present on and off, with some central nervous system symptoms with fogginess and word-finding difficulties, poor memory, gait balance, and again, evaluation with MRI and EEG was normal. She had peripheral neuropathy. She had lipoid dystrophies that was thought to be related to chronic GVHD and insulin resistance. And then she had renal involvement, and she was extensively evaluated by our colleagues from renal department, and she had nephrotic syndrome and nephrotic range proteinuria. They were unable to do actually kidney biopsy because she would have severe skin pain after lidocaine injections. And then she was started on cyclosporin, primarily for renal involvement, and she responded well to it. And with time, her kidney function normalized and her nephrotic syndrome resolved, and she responded to cyclosporin. And she also had some evidence of serositis with periodic pleural effusions. And this is a picture of her skin. She also had very interesting calcium deposits in her skin, and the punch biopsy showed morpha protunda with dystrophic calcifications. And of course, even when her severe sclerotic manifestations would get better with treatment, this calcification would still be present. They would sometimes appear maybe a little softer overall, but they would persist. And she is a nice example of somebody who was treated again for a period of 12, 14 years and was on variety of medications, essentially everything that we can think of using for chronic GVHD. She was very early on ruxolitinib when she got it through compassionate use. She was on ixazomib trial. She was on ibrutinib. We tried to get baricitinib, but it was denied. When belumosudil trial was available, we screened her, but she received too many prior therapies to be eligible. Then there was nothing available at the time, so ruxolitinib was restarted. And she had at that time, I remember I took care of her during that period of time, and she had a very decent response for ruxolitinib for a period of time, but then continued to progress. And then finally, when belumosudil was available, she was tried for about a year on belumosudil, and again had initial response with some skin softening, and most actually of her atypical manifestation have resolved. Her kidney function normalized even on cyclosporin, her cognitive functions improved, her edema resolved, but she continued to struggle with sclerotic GVHD. And as of just last month, she started oxalitinib as a compassionate use because she also wasn't eligible for the protocol. So I can again stop here and kind of bring it back to Jeff as an example how sometimes these atypical manifestations can respond to treatment and can reappear as we taper immunosuppression.
Yeah, thank you. This is when I was reviewing this case on your slides, I was taken by this laundry list of chronic graft versus host disease medications and kind of feeling a bit stuck as to what one might consider next, given that you've really tried what really are sort of the 2020 to at least consider to be the major medications. And I guess I would send a comment back to you, and this is every time that I have sort of listened to any of these new trials coming on out, is I'm wondering from a larger perspective whether we have to start thinking about this in a little different way, where we may need to begin to multiple combination of these medications into different mechanisms. And that may be, all the trials that we see, they're usually one medication and seeing 30 to 50% response rates. But I'm actually wondering if one thing we've learned, for instance, from targeted oncology is that you may target one pathway and another pathway just gets upregulated. I'm wondering if that maybe, if you had any comment on whether we need more than one drug at a time.
Yeah, no, I absolutely agree with you. And in a real life, we will often have patients who have been, let's say, on ruxolitinib, and then they stop responding or have a little bit of progression. And then nowadays we will add belumosudil, but not necessarily stop ruxolitinib, but maybe adjust the dose a little bit, lower the dose one level down, and then continue 2 drugs together, considering that they have a different mechanism of action and could possibly work together without overwhelming immune suppression. They're not so severely immunosuppressed and without additional side effect.
And Iskra and Jeff, do you use steroids only at the beginning, or did you use that persistently throughout the entire treatment time?
You said steroids?
Yeah, the prednisone.
Well, usually I would say only at the beginning. I think that most of these people who have been through all these different various manifestation drugs for GVHD are either not on steroids, or they're on some very minimal dose that might be really used to control adrenal insufficiency or something of that. But none of them are on high doses of steroids. I would say maximum up to 10 milligrams, and typically they have seen a fair share of steroid pulses, so we don't typically keep them on steroids. We might use.
And go ahead.
No, please.
There's a couple questions that have come up, and I think maybe we could put these in before we go to case 3. And I think one of them was around back on the myositis and use of ancillary support by pain services and palliative teams. And your experience, both of you, with that. Certainly, I know at our center we do and find it very useful, but you want to comment on that?
Absolutely. Thank you for that question. Yes, I didn't include that in the presentation, but absolutely we include the pain team, and we use variety of ancillary measures to help this patient out, include our colleagues from physical therapy and occupational therapy, and try variety of ancillary measures that can often be of a lot of help in these patients. I'm actually illustrating that a little bit more in the case 3, but I think that this is an essential part of treatment of chronic GVHD.
Mm-hmm.
And maybe to both of you I'm sorry, go ahead, Jeff.
I just was good. I completely agree. And the other component is that if your center has a chronic pain clinic that looks at a variety of non-pharmacological things like biofeedback and the like, that can also be very helpful.
And then just another one, and I think I'll kind of make it a bit more of a general question, but Dr. Gandhi had asked about adding in ECP in combination, but the combinations, do you try to do 2 or 3 drugs and synergize mechanisms, something like ECP plus ruxolitinib or something else? And what is your thoughts about that, both of you?
Well, I would say absolutely. And the problem is ECP was that when these drugs were in their early trials, then they could not be on ECP. This was one of the exclusion criteria. So many of these people have stopped ECP before going on these trials. But when the trials are done, or if they're not on trials, then absolutely we try to keep them on ECP and then add some of these new drugs to it and combine drugs, as we already said.
Okay,
thanks. Jeff, any other additional?
No, I would completely agree with that. I mean, ECP is a really nice background thing to do. I'm not certain if every center is the same. Ours, we don't need to have the kind of approvals that might be needed for a variety of drugs. So it's easy to stay on ECP while you may be on a different drug at the same time.
And I guess I'll just bang the drum that I've been banging a little bit the last year or so, is that I do think we need to start thinking, now that we have some approved agents and ones that we know efficacy, we need to start thinking about synergistic mechanisms and whether there are combinations of 2 drugs or 3 drugs that make sense and should be evaluated in trials, similar to the way we do chemotherapy or anything else. But I just put that out there. I think we need to start moving on. We do single agent a lot of times, and we need to start thinking about combinations, especially with these atypical manifestations.
Yeah, I agree.
Okay, Iskra, take it away on the 3rd, please.
very briefly, the third case was a man who is now 74. He was 62 at the time when he got his transplant. He got Bucite conditioning, had some skin acute GVHD grade 2 that resolved. And then he was on the cytobin maintenance study for, I think, 6 or 8 months after his transplant. And then after that, towards the end of that study, he started developing some neuropathy that then progressed to really severe sensation of skin, feeling like some sunburns that initially was thought just being a part of neuropathy, but then he developed more tingling and hypersensitivity, some areas of lichenoid changes, but nothing overwhelming. Mostly this was this intense burning and pruritus, and then allodynia and hyperalgesia to the point that he was really unable to wear regular clothes. And he developed also proximal muscle weakness. The enzymes were normal, aldolase, CK were normal, or other evaluation, nothing really revealed anything abnormal on his testing. And the only other side of chronic GVHD was some mild to moderate eye chronic GVHD involvement. So his skin biopsy showed no inflammation and just some eosinophil in dermis and some evidence of lichenoid chronic GVHD. But then further biopsies showed and proved that he had small fiber neuropathy. And you can see here the levels that are smaller, that are shorter than normal levels. And again, the full evaluation with MRI and EMG and nerve conduction studies were normal, and there was no evidence of large fiber neuropathy. Q-sweat study were normal, there were no infections, all his medications were reviewed and excluded as potential culprits. So he was again treated with usual suspects here with various additional therapies to help with this pain, such as pregabalin, duloxetine, amitriptyline, lidocaine. He was started on ECP. He was sent to our colleagues at NIH, where he was actually seen by Dr. Jay Shah, who is the world-renowned specialist for small fiber neuropathy. And it was recommended to start him on vitamin E for some antioxidant properties. But despite everything that was done, his condition really was not getting better. And we tried to obtain ruxolitinib for him and eventually were able to get it in 2017. He had some improvement, but he still continued to have allodynia. And then belumosudil was just this year added. He was on it for about a month, but he didn't have response. And then he stopped it because high copay, but I think current plan is to add belumosudil and see whether that can give him some relief. But I think that currently it's somewhat stable and he learned to live with it, but it is not resolved. And I bring this as a case to show challenges in diagnosing this kind of atypical manifestations when aside of that, there is only minimal chronic GVHD otherwise. And treatment decisions when diagnosis is uncertain. So any other comments from Jeff or Kirk?
Yeah, I mean, I think that this really shows, as you stated, the challenges and really the poor quality of life that often happen. And again, also shows where you see this as a problem, but not a lot of other chronic GVHD stuff, maybe a little bit of skin and lichenoid changes here. So it really emphasizes why these sorts of patients need to get onto chronic GVHD clinical trials so we can start to learn more.
Yeah.
I think I'd like to, since we have about 6 minutes left, just to stay on the time, I'd like to open it up for some additional questions, either on this case or just in general. Either raise your hand or type it in. If you're shy, type it into the chat. And I'm just looking to see if anybody's raised their hand. Otherwise, I am going to ask you guys a couple questions myself. If I have to, we're going to. Okay, I don't see anybody. Everybody's being a little shy today. Both of you, I guess I want to go back to the steroid issue. We all hate it. But the question comes down to the anti-inflammatory impact and the mechanistic impact of steroids. Are they necessary? Because there's this whole question around refractory versus dependent steroids, in GVHD. And do you want to comment on that in atypical GVHD on whether it's necessary to always combine with steroids or not? I think, Iskra, you're expressing the opinion not to, but I'd just like to hear a bit more.
I would not necessarily say not to. I think often when we have somebody, when we are designing trials, for example, we often will allow a brief pulse of steroids at the beginning to kind of cool off GVHD manifestations. And I think that particularly with atypical manifestations that they might respond to a pulse of steroids. So I'm not completely opposed to it. I think that on a long run, we have to have better ideas, but that in somebody who has not seen a pulse of steroids for a period of time, giving a pulse of steroids and giving it a shot is a very reasonable idea and something I would do, particularly for atypical manifestations.
It may also impact as to what the atypical manifestation of what you're seeing. Many of, for instance, the autoimmune hemolytic anemias or the ITPs can be very chronic, lasting years. And, one perhaps doesn't want to start getting into a situation where you're getting so anemic and that you're needing multiple blood transfusions. And the reality is steroids do often bring hemoglobins up in those scenarios. And you may need to have periods where you're on more steroids and less. So I think it also depends a lot upon what the atypical manifestation is.
Okay, and I got one more question for you guys. It's a bit on the controversial side, but do we need to have a revision of the NIH diagnostic criteria to expand them to include all the atypical manifestation? Right now, you can still say a patient doesn't have chronic GVHD with the NIH criteria, but they have atypical manifestations. And the question is, should they be modified? Should we be proposing that?
I would suggest the answer to that is yes. We have in the paper that we published earlier, we tried to acknowledge that there are many confounding factors, but in the end, I think that we have some data that chronic GVHD affects kidneys and including the biopsy data that shows that. We now have mouse model for central nervous system. So I think that we should begin to start to think about modifying those diagnostic criteria.
Iskra, your thoughts? And Steve Pavletic, I see you on here, so I'm going to point you out and say I want to hear your comment on this. Go ahead, Iskra.
Well, I could say kind of it can go both ways. For the fun of it, I can just say maybe I can say no, we don't need to modify them, but what we need to do is that we need to document in details what the manifestations are and say that the manifestations could be related to chronic GVHD, kind of what we are doing now, because it's not always that certain, and there are often a lot of confounding factors with these people that could cause them to have some of these manifestations. Sometimes you can do kidney biopsy, it can be relatively easy, but with cognitive or some of peripheral neuropathy, it's not always that easy to just blame it on GVHD.
Steve, any additional thoughts? You're looking very thoughtful there.
Oh, yeah, I don't see myself here, but I'm glad you think so. Oh, okay. Well, first, of course, everything's been said. Great session. Thanks, everybody. It's an evolving area. Atypical manifestations actually are, right, part of the NIH diagnostic criteria if they are associated with some distinctive or diagnostic signs. So it's really that it's not that they're not and they're listed on the forms. It's just a matter when they come in isolation, oh, this patient has CNS chronic GVHD. I mean, right, it's hard to accept something that's so rare, but it's undeniable. There's and so on, strong evidence. So this is why we are proposing to improve our tracking of this, right? Really trying to understand the true magnitude of the problem and improve our studying. It's our sense that vast majority of these cases don't get really registered. We hear a lot, talking to each other, but it sort of goes somewhere into waste bag, and we do very poor job in studying those. So I totally agree. Could this be on the philosophical level, chronic GVHD? Sure, because we know that Ken Cook's paper that 2017 Jeff showed, it's three pathophysiological pathways, right? Inflammation, fibrosis, dysregulation, and all those go under dysregulation. So sure, you can say that's kind of part of the spectrum of the disordered, immunity in chronic GVHD. If we decide one day to call it so, well, then we're going to need a fourth consensus or something, but it's, we need to study this much better.
Thank you, Stephen, for that. I'm sorry we're running out of time. Iskra, if you could stop sharing your screen. I have about three or four administrative slides just to run through for everybody, so you know how to hang on. And let me just take this up. So this is just some administrative stuff. There we go. If you want credit, there's the link, and you will see this. It'll be emailed to you. So to get your CE credit, just to give you a couple announcements, there are future interactive ones. One is planned in January on a whole bunch of the complications of chronic GVHD and supportive care. If it's like all the ones so far, it's going to be fantastic. And just to also providing equitable and inclusive care for patients on November 4th. And lastly, the quality of life pre-transplant, post-transplant, again, for an on-demand course. And I apologize, we didn't realize this till it's too late, that we had scheduled this during the virtual workshop. So I think you can still register, and it is ongoing right now. And I encourage you to try and get on that. I've registered, and I'm going to go on it pretty soon. Oh yes, and then the Meredith Foundation, Cowden Foundation, will be having a session on January 27th, how to choose drugs for chronic GVHD, and Joseph Padala will be talking about that. And that's it. Thank you so much sorry we ran over a couple minutes, but thank you very much.
Thank you, everybody.
Thank you.
Bye.
Thank you, everybody. Bye.